behavioral medications. That's going to be a separate talk, but I'll have one slide on it. So what is the purpose and value of these in any, all-cause dementia, but specifically Alzheimer's disease and Lewy body disease? So objectives wise, I'm going to, at least talk about what drugs have been approved for this. And then also kind of when should you start medications. I'll make an argument for maybe some off-label usage here. We'll talk about tips for dealing with side effects, getting creative with dosing, especially of acetylcholinesterase inhibitors, because that's kind of all we have. So it is important to get creative with those. When is the time to stop medications? I often get that question. We'll have a couple slides on aducanumab, but that's less of an issue these days, and we'll talk about why. So disclosures wise, I'm going to talk about some off-label use, one being in the mild cognitive impairment stage, particularly if your most likely etiology is a neurodegenerative or Alzheimer's disease type of cause. And then Lewy body disease, it's still technically off-label, but it works so well in that group of patients that I will shout that from the mountaintops. Here's just quick, timeline of medications that have been approved. So these first three, which really go back 2 decades now, and even further for donepezil, they're all in this group that we call cholinesterase inhibitors, right? So they're basically increasing acetylcholine in the brain. I've shown sort of the brand names and the generics here. There are a couple differences with galantamine and rivastigmine. They're not exactly like donepezil, but their main mechanism is still increasing acetylcholine. The other one here that we see in 2003, so almost 2 decades ago, was memantine or Namenda. This works through some modification of NMDA receptors, but its exact mechanism is not entirely clear, perhaps to reduce calcium influx that might contribute to cellular death. And these drugs, all these ones that are listed here, I also showed the one, Namzaric is the combo pill of memantine and donepezil. And they work okay for Alzheimer's disease, but really, especially this class of medications, works very well for Lewy body disease. The aducanumab story is ongoing, but we'll talk about that at the end. A lot of question marks there. And so those first 3 drugs I showed you are basically based on the cholinergic hypothesis. So what is that? It was really kind of the late 70s and early 80s that really recognizing that parts of the brain, particularly this nucleus basalis of Meinert, which is shown right here in green, that there was atrophy in those regions, and there was less acetylcholine projecting neurons, particularly to the rest of the cortex, which is really important for cognition, attention, focus, working memory, and memory in general. So that was kind of the leading theory here. And then so developing these drugs was trying to increase acetylcholine. And the way that these drugs work is by basically blocking the breakdown of these. So whenever neurons talk to each other, they release acetylcholine, and that's basically how most of cognition works. But they get broken down quickly by this acetylcholinesterase enzyme. And so we're basically blocking this enzyme, keeping acetylcholine available longer. And it's a similar but not same idea behind how we're supplementing dopamine with Parkinson's patients that have low dopamine levels from loss of those neurons. So that's the general mechanism here. And it really also highlights why we stress removing anticholinergics, right? So there's been multiple studies looking at this, but cognition, brain metabolism, brain atrophy, even in cognitively normal older adults, were all associated with anticholinergic medication use. And that's basically accelerated for those that have cognitive problems, because those patients that have cognitive problems already have a cholinergic deficit, and then you're blocking it further. Here's like how complicated it can get. So, I'll have these in the slides, but this is a whole list and different mechanisms and why we use these drugs. But just to simplify it a little bit, these are our most common offenders, particularly oxybutynin, Benadryl or diphenhydramine, hydroxyzine, antidepressant and sleep aids like amitriptyline, nortriptyline, even an SSRI like paroxetine has pretty significant anticholinergic effects. So these are the things to keep in mind when you're seeing patients with memory issues. You've got to remove the offending agents. And I'll often see patients on some of these cholinergic blockers while also being on the donepezil. They're basically just combating each other, right? As far as like the AAN guidelines, which is our American Academy of Neurology, the last time they updated this was in 2017. But they suggest for mild cognitive impairment that there's really only level B evidence. So they still consider it off label. You may choose not to offer those, right? Those medications. And part of it is their studies suggested that there might be lacking efficacy in this stage of the disease. And there was such high, side effects that they might have outweighed those. But I'm going to show you. So one of the studies that these guidelines were based on, it was called the Alzheimer's Disease Cooperative Study. It was done in 2016, 2017, results in 2017. These were a large part of why the guidelines suggested against MCI. There was a group a year after that kind of looked at more details here. And, when they really looked at the neuropsychologic testing, which is really how we diagnose MCI, they found that about 30% of patients were misclassified. So this was kind of the breakdown of all the different cognitive tests and everything. And so on the left here is folks that had what we call single domain amnestic MCI. So it's this short-term memory difficulties is what these bars are indicating. And certainly below a Z-score of -2 is definitely abnormal. So that's 2 standard deviations away from normal. Some go off of the 1.5 standard deviation. Here is the multi-domain. So not just the short-term memory, but you're getting some language or executive function. And these are the different cognitive tests labeled up here. There was 30% that were really in a false positive MCI group. So while they had some mild deficits, they were barely below -0.5 Z-score and really should not have been classified as MCI. And MCI diagnosis is hard, but we do really rely on normative-based data to see are patients having objective cognitive abnormalities, right? Because there's many patients that have subjective concerns, but if they don't have objective abnormalities, they shouldn't be diagnosed with MCI, and they would really fall more under this subjective cognitive impairment. And we had this slide near the beginning of these sessions when we were talking about that normal versus abnormal aging, but it really highlights this subjective cognitive decline or subjective cognitive impairment group, right? And oftentimes, so objective memory performance is on blue here. Once somebody meets a threshold that's of clear impairment, then that's where we start to diagnose MCI. But there's definitely a phase of worsening that we can't fully capture unless we have multiple data points. And still we wait for that threshold before we change the diagnosis. But this is something to keep in mind, that this is an evolving concept, and many studies are catching up with that, right? So if you kind of remove the false positives, placebo being in the dotted line with sort of checking at 6-month intervals here, those that were on the donepezil group, there was certainly still decline. And this is sort of progression to dementia stage of Alzheimer's disease. Over a 3-year period, still many of them were starting to match this, but still 50% were not in a dementia stage. And at each time point here, it was different from the placebo group, right? So that was the main takeaway here, that it does seem to have some positive effect even in the MCI group. We know short-term data supports donepezil use, but many studies are just, this one was only 24 weeks, or you'll get some that are up to 52 weeks, but long-term data has been kind of lacking in most of our studies. There have been 2 that have been published here in the last year. So one was a Swedish dementia registry where they were able to look at 16,000 patients with over 5 years of data. And they showed in that study that there was reduced mortality, basically consistent with some prior studies of reduced stroke, MI. The benefits were more in the galantamine group than the other 2, but they all met significance on statistics there. On that study, there was also reduced conversion to severe dementia, but I'll tell you, those numbers were on the lower side. And galantamine was the one that reached the statistical significance in that domain. There was most recently, just a couple of weeks ago, a study out of China that really looked at 13-year follow-up. And if patients were started on that early on, they actually had a delayed onset of cognitive decline by cognitive testing by about 6 years compared to those that were not on the drug. And when you look at even longer time, even once these patients started to decline, even at the end of the study, it was still almost a twice point increase decline on those that did not have the drug. And similar to this study, the reduced mortality was about a hazard ratio of 0.59. So we're getting short-term data, which we've always known, but also long-term data that these drugs do make a difference. And so this is kind of how Jeff Burns and I conceptually think about this, right? It's like if you've got some clear changes, maybe you're in an MCI range or a mild dementia range, and you initiate these cholinesterase inhibitors, there's actually a plateau period, particularly with when we do cognitive testing. Sometimes that's 12 months, sometimes that's 2 years. It's very patient dependent. But then you're still going to end up, this does not change the underlying biology, right? The amyloid and tau changes. It's just supporting the brain and helping support memory function. So there's still going to be decline, but that's going to be at least perceptively delayed, right? By these medications. And then at a later stage, more of at a moderate dementia stage for most patients, initiating memantine can see a similar, not quite a plateau, but a similar benefit, but still with eventual decline. And really, that's what our goals are here, right? We're trying to slow decline with these medications. And so as a summary with all that, right, should my patient be on one of these drugs? I would argue, and I didn't show you Lewy body data, but I can tell you, based on clinical trials that have been done and just anecdotally, these work very well in patients with Lewy body disease. And so I'd say absolutely yes in that. And I would say for both the mild cognitive impairment and dementia stage, you should be having your patients on these medications. For Alzheimer's disease, I will say yes, emphatically there. Again, we talked about the short-term, long-term. And then for the MCI stage, I'll say probably, although that does have to be off-label. And the reason I say probably is oftentimes it's difficult, especially for non-specialists, to know exactly, is this early Alzheimer's, or could it be medication side effects from those medications I listed earlier? Absolutely. Could it be a sleep apnea problem that's driving the MCI? Absolutely. Could it be anxiety and depression? Absolutely. In the future, right, where we're able to get like blood tests for Alzheimer's proteins, we'll be able to pretty easily say, yes, most of your symptoms are due to this early Alzheimer's process. But right now we rely on the detailed cognitive testing. So if you've got a pattern that the neuropsychologist is describing as a short-term memory predominant problem, then that's, especially if you're dealing with somebody in their 65 to 75 year age range, right, that the most likely cause of that is early Alzheimer's. So if you see that pattern, that would be a reason to start that medication. For vascular disease, I say probably not. And the reason I don't say definitively not is some studies have showed benefit in these folks, and I suspect that a lot of those have an overlap of cases with vascular disease, but also Alzheimer's disease. And maybe that's why we see some benefit. There has been no evidence in FTD or frontotemporal disease that these benefit. And some studies actually show worsening of behavior symptoms. So the key reason being is they're not really acetylcholine deficient, and they don't need a boost in that neurotransmitter. So some tips with these, right? We often run into issues when starting this, and I will invariably see patients started on memantine before donepezil, and I suspect the main reason is there's a lot less side effects, and we don't have to deal with that, right? But you should be starting donepezil first. It's absolutely indicated before memantine. I recommend giving it in the morning with protein. Generally, we want to increase slowly. So if you've got somebody with like a low BMI, particularly below 20, you might even start this at 2.5. Or somebody with kidney function issues, right? You're going to want to start it even slower. You shouldn't increase it faster than 4 weeks. Some even recommend waiting up to 3 months to increase. But you're going to eventually want to get them to the standard dose, with donepezil is about 10 milligrams. Now, if they tolerate the 5 just fine, all of a sudden they're having lots of issues on the 10, then that's where you need to get creative, right? And try splitting the doses, where we could do with meals in the morning and at dinner time. And then that way they're able to still get the 10 milligrams in, but not necessarily all at once, right? And I will push doses higher, especially if it seems to be benefiting patients. So in my DLB patients, they'll often be on higher doses, or in kind of my young onset working memory Alzheimer's cases. I don't ever give the 20 milligrams all at once, but really more of in divided doses, just to help with that GI symptom tolerability. There is a sustained release tablet out there, a 23 milligram tablet. I'm not convinced that's generic yet. It might be, but it still seems to be quite a bit more expensive than these pills here. And most bioavailability studies suggest 10 milligrams BID is about the same as this. So if you've got a patient that really wants to reduce their pill burden or can't remember the dinner dose, you could consider that. The issue with giving it at nighttime is often related to insomnia, increased nightmares, or if the patient does have REM sleep behavior disorder, it can substantially worsen that. If your patient's already taking it at nighttime and there's no concerns, you could just leave it alone. It's not always worth moving. But I'll kind of show, actually one of the reasons for this is you're basically getting a peak of the drug during nighttime. So it is going to reduce the side effects of GI if that's what's going on. But you're also not getting as much bang for your buck for when this drug is peaking, right? While they're sleeping. And that's what can contribute to the insomnia too. There are galantamine formulations of this, like we talked about at the beginning. There's also an extended release version or a twice daily version of this. And 16 is kind of the standard dose there. When you look at kind of the patch versus the pill of rivastigmine, so I don't ever use rivastigmine oral, and I always use this bioavailability graph as my reasoning, right? So on the dotted line here is the pill. You have to take it twice a day. So it's already a ding on that medicine compared to donepezil. It peaks very quickly, and then it drops off fairly quickly, right? It's these peaks that are causing the side effects. And the patch, so the highest dose patch here, the kind of standard dose patch here, you're getting kind of continuous release throughout 24 hours of a therapeutic level rather than these spikes that we see. And so the patch, the only main thing is there's got to be good skin care. You've got to rotate the skin site. There's a lot of potential irritant contact dermatitis, but it's pretty rare to have allergic contact dermatitis. So good skin care is important. The pricing of rivastigmine patches is primarily what limits us. Like, why don't I just start that all the time? It's cost. And the cost has no rhyme or reason why it's, almost 3 times the cost at Walgreens as it is at Dillon's here, right? This is an old slide, by the way. This could have changed a little bit, but these bounce around and there's really no rhyme or reason that I can find of why this occurs. We've been partnering with a pharmacy that's a mail-in order. So they basically price match the bestgoodrx.com price. It's called Manifest Pharmacy. And so they've been good to deal with. So patients don't have to drive around to find the cheapest price or have it sent to their pharmacy for any reason. As far as other complications with these, so, these drugs very commonly cause GI symptoms. So diarrhea, nausea, vomiting. It's important to counsel your patients. What does acetylcholine do in your stomach? Well, it helps you digest food. So, basically we're increasing the availability of acetylcholine throughout the system, not just in the brain. So it's going to stimulate the gut. It's going to move things along. And so if somebody takes this on an empty stomach, I can almost guarantee you they're going to get GI related symptoms. Rivastigmine oral by far and away has the most common side effects. And that's why I basically just crossed this off the list of prescribing. I start with donepezil here, but still 20 to 25% is a pretty high quote unquote side effect rate, kind of what the body's designed to do, right? Whereas if you see this rivastigmine patch, it's much lower, almost 5 times lower. And the galantamine, especially the extended release, is somewhere between 10 and 15. So it kind of falls in between these two. Muscle cramps are also an issue, especially for those that have baseline muscle cramping issues that can get exacerbated. Acetylcholine is also important for muscle contraction. So that is partly why we might see that. And then you also have to think about the heart. So particularly if your patient starts describing lightheadedness, a lot of fatigue, just wanting to sleep all day, right? You definitely need to evaluate the heart. Could there be bradycardia here? Could they be having other cardiac issues? Most people don't recommend a baseline EKG for everyone, but if they've had a cardiac history or they have bradycardia, then we would recommend it, or if they're on other agents that could be prolonging QTC. And then you might want to repeat that down the road. And so you may need to have a cardiology consult, get a full cardiac workup if needed, if that seems to be the issue there. So you've started your patient on it, they've been on it for many years, when is the time to stop it? I mean, the easiest statement there is when the negatives are outweighing the positives. And I will tell you that I say that's an easy statement, but oftentimes patients aren't sure, is this drug doing anything or not? Particularly when the disease process is still a stepwise, it's a decline over time, right? So we might be leveling that out a little bit, but it's hard to know if they haven't been off of it. We don't generally trial a recommendation just to see if it was doing something, though, because we have seen cases of, especially if patients are just stop it, then the brain has a lot of chemistry with these receptors that all of a sudden, it's expecting some level of this drug and all of a sudden it's not getting it. Patients can have irreversible cognitive loss from that. So if you are going to think about stopping it, ideally you want to titrate off of it. And really you want to be doing it because of side effects, not, hey, we wanted to see if this is working or not. Certainly if patients are at later stages of the disease and patients just want to lower their pill burden, then there might be some reason to just come off of it for that reason. Weight loss is part of the disease. We see a lot of muscle mass loss. We have other reasons why patients are forgetting to eat, right? Weight loss is part of the disease for a couple of different reasons, but if it's accelerating further, especially if they're not hungry, and they're having a lot of weight loss, then you might want to back off the dose at the very least. GI symptoms, muscle cramping, all these, especially if they're just something that if they're impacting their quality of life, then you have to reassess that. And again, get creative, right? If they're having a lot of diarrhea, do the split form, do the extended release form, do the patch form, right? Those are options for us. Should I start Memantine? So it's FDA approved for moderate to severe dementia. We find that it typically helps more with behavioral symptoms than cognitive, but as far as side effects, it's usually very well tolerated. And it seems to have, at least for a cognitive side of things, a slight synergistic effect with donepezil. So we don't recommend prescribing it on its own in most cases. Obviously, if somebody's on it and they want to stay on it, you don't have to take them off, but it's really, the studies show a synergistic effect here. Lewy body disease, it's less clear how much this helps. And then frontotemporal disease, there's been no benefit in multiple studies. There is the combo drug I mentioned earlier. This is a good option for some patients that have really good insurance, or just they don't care how much it costs. They want to lower their pill burden. That'd be the only reason I'd consider this, though. From sort of a non-cognitive symptoms, I just wanted to include this one slide. Again, we'll have a separate talk on behavioral stuff, but it's important to realize that cholinesterase inhibitors and memantine, both of them treat non-cognitive symptoms too. So for example, visual hallucinations in Lewy body patients, the first line of therapy is cholinesterase inhibitors. And the second line is cholinesterase inhibitors. Like, that's just how well it works. So we do recommend these first line for many of these, actually. But for those that have excessive depression, anxiety, which is very, very common, especially the anxiety side of things, SSRIs are indicated. We generally stick with escitalopram or Lexapro. Sertraline's another decent option, but it does carry a higher GI side effect rate. So if they're already sensitive and they're on donepezil, it's not as good of an option. For agitation, non-pharmacologic strategies are still the best in front line there. Low doses of trazodone or quetiapine are used. Hallucinations, quetiapine, clozapine is actually very good, but it's like almost impossible to prescribe with the protocols that need to be done. And then pimavanserin we've been using more and more, and this can help in many cases with hallucinations. Sleep, we'll talk about, we'll have a whole sleep talk as well, so I'm not going to stick on that. So I often get asked about aducanumab or Aduhelm, right? Well, first, how does it work? Well, it clears amyloid out of the brain. So we have these amyloid plaques that are developing outside the neurons, and this basically tags those amyloid plaques. It's an antibody that tags them, so it's given intravenously, and it triggers the immune system to come in and clear out the amyloid plaques, right? This actually works quite well. So this graph here shows On placebo, there's really no change in amyloid plaques measured by an amyloid PET scan over the 78-week period here. Whereas the low dose in blue and the high dose in green had significant decrease, over 30% reduction in the plaque burden in these individuals, to the point where many of these individuals actually become amyloid negative on the amyloid PET scan. And it was this sort of evidence that the FDA did approve this medication. It's hitting its target. It's doing a pretty darn good job of hitting its target. But they did not approve this based on clinical benefit, and they list that as indeterminate at this time. The reason with this is multifactorial, and I don't, unless somebody's very curious, I can go into details, but basically there was two arms of the study. One of them was positive, one was no difference from placebo. And so it's sort of, it didn't meet its end goals of both of these studies being positive. So that created a lot of controversy, especially for us specialists in the field. If you want to give this drug like the best of light, again, you'd look at the amyloid reduction, which we just showed. There was some leveling off of functional decline over, especially once you reached kind of after a year, you started to see a divergence of the placebo group and the drug group. So again, this is not a cure. It may help. It may be something that in conjunction with other therapies in the future might help some. My suspicion is the earlier this is started, the better. So for most patients with dementia, it's not going to be a good choice. But in the MCI stage, and particularly when amyloid's there before patients develop cognitive decline, that might be where this ends up going. We're actually actively studying that right now. But this is best of light. I'm not showing you the one that really these lines look the same. So this was about a 20 to 25% reduction in decline is what was reported. But there are side effects of this. It's not like this is a benign drug, right? I just mentioned this is a big IV medication that's activating the immune system. So in some cases, you can get this. This is a severe case. This is not what we typically see, but you can get this swelling within the brain tissue from basically an overactivation of the immune system. And so we call this ARIA-E for edema. You can also get microhemorrhages, so small brain bleeds called ARIA-H. And these can occur in about 40% of patients. So about 30-some% of edema and another 6 to 10% of the small hemorrhages. They're more commonly to occur in ApoE4 carriers. And they often occur early on, but it's actually as you get up to the higher doses where we see it. And these resolve. So if you pause the medication, these will resolve in the vast majority of cases, over 90%. Most patients are asymptomatic, so we really pick these up by screening exams, right? And then others can be more non-specific symptoms. There have been a few severe cases of hospitalization as well, and actually death from the brain swelling. So why I say we don't need to spend too much time on this, we don't really have to actively think about should we be prescribing Aduhelm or not in patients, because currently Medicare came out and said, we're not going to cover this drug based on the lack of evidence unless somebody's enrolled in a clinical trial. So Biogen has respectively and appropriately started this phase 4 trial. So this has been official. The protocol is finished. This is supposed to be more of a definitive trial, and we're going to be targeting over 1,500 participants. KU will be a side of this, and it's going to be enrolling in the next few weeks. And one of the goals of the study, because one of the limitations of the prior one is, even if we said, oh yeah, this looks great, this is great data, we had no data on minority patients, because it was like 91% white, and then another 8% were Asian, because there were Asian sites involved in this study. So a goal of increasing that diversity within the study is part of this. Patients have to be in that sort of MCI or very mild dementia range. They're going to require AD biomarkers to be positive. So that'll be part of the screening process of enrolling for this. And then you can't have microhemorrhages beyond 4 at baseline, because that's where we know there's an increased risk of those hemorrhages going forwards. So a lot of information. I see many things in the chat box here. So let me stop sharing here when we'll start to address some of these questions. So I'll let Kelsey or the team set up their rotating slides. So I'm scrolling back up here. Which drugs were used in the China study? So Michael, that's an excellent question. I actually need, that report, it was as an abstract that was really in the last, I think it was a week or two that I saw it in my inbox, and I need to go into the details of that study, exactly which ones. But very similar results to the Sweden study as far as both the decreased hazard ratio on overall mortality over time, as well as benefits, for long-term cognition. Wendy asked a question here of, do these meds help those with subjective cognitive impairment? And then there's another question, do you recommend treating subjective cognitive impairment? So currently, no, we don't have any evidence to do that. There's theory to suggest why. We know that these diseases happen on a time scale of decades. So there is cholinergic loss in the system well before we can detect it on cognitive, on cognitive testing. However, there's so many causes of subjective cognitive impairment. People have their radar up, right? And the side effect rate of these would almost certainly exceed our ability to say, oh yeah, your subjective cognitive impairment is due to, an Alzheimer's disease process. I think if we get to a point, and this is like in the long future, where patients are just coming in with amyloid markers, what are my risks for developing Alzheimer's? And they have a genetic history, or they have a family history, and they've got some abnormal amyloid and early biomarkers showing that this is probably along that Alzheimer's continuum, then that might be a reason to start that in those individuals, but not where we are currently. I would not recommend it. So Robert asked a good question. Do you not use donepezil and FTD even for PPA? So that's an excellent question. It's actually more complicated than on the surface. So primary progressive aphasia has that's the language variant for everyone that we talked about a week or 2 weeks ago. That classically got just classified under the FTD umbrella, but there are many cases of primary progressive aphasia that are due to Alzheimer's disease. So I wouldn't regard those as FTD syndromes. They are a subset of these primary progressive aphasia patients. So if you've got someone where a language specialist or you're pretty confident that has diagnosed them more with a logopenic variant, which is the classic Alzheimer's one, then I do start those individuals on donepezil. But for ones that have a non-fluent or semantic variant of FTD, I do not start donepezil in those. And that's one of my arguments, honestly, for why I get a PET scan, because it does change management. And it's also helpful in having a more concrete diagnosis. So, so another good question here with weight. So underweight, less than 110 pounds. It's a good question. I think for most of my patients, I'd recommend lower. You're just more likely to get side effects at the higher, or at higher doses for patients that have a lower weight. So it never hurts to start low and go slow in our patients, especially in folks as they get older. So I think that's a pretty good cutoff there. Certainly below 100, but 110 might be a good cutoff. And then, so yeah, Kelsey helped out with the GoodRx. And on GoodRx, you can search the different, so the one I showed you was for rivastigmine. Dr. Daniels asked to go in here, do you recommend acetylcholinesterase inhibitor for those with dementia due to normal pressure hydrocephalus? So again, a good question, but more complicated than on the surface. So I say that as someone that has done a lot of research in normal pressure hydrocephalus. I've published papers on it. And so there are actually some neurologists out there that don't believe normal pressure hydrocephalus is a real thing. I am not one of those, obviously. The problem is the average age of onset of NPH is age 75, and very often there is going to be co-pathology, right? So that's partly why I recommend a PET scan that's what I do when I'm working these patients up, a glucose PET scan, because if I'm seeing a pattern of Alzheimer's disease on top of their clear NPH syndrome, then I wouldn't recommend that a shunt is going to help their memory, right? Because it's very unlikely to. It still is going to have potential quality of life benefits from from their gait and their overall getting around and reducing falls. So I will still recommend a shunt, but in the proper counseling of, hey, you've got this other thing that's driving the memory issue, and that's going to get worse with time. In those individuals, yes, I will start an acetylcholinesterase inhibitor but not because of NPH, because of their copathology, which unfortunately is very common to have both. Is there a link to the anticholinergic pocket? So I just pulled that actually 2 days ago. It's going to be in the slides, Robert. So if you reach out to the, that will be listed in the EADS link, where you get your CE credit. We'll have the PowerPoint listed there. I think it'll be in a PDF form, but you can find it in there.
Dr. Townley, I wasn't sure if you saw the question from Dr. Colasar or if I just missed you answering that question.
The original one, right? The
China study versus.
Yeah. I addressed that one.
Perfect. Thank you.
These are really good questions. For those that asked about the NPH and the PPA question, does that make sense? When I kind of, and that's another reason to. So like one of the things I also do when I'm doing the normal pressure hydrocephalus workup, when I'm getting a high volume lumbar puncture, I'm collecting spinal fluid, right? And so we have a process where we have the physical therapist evaluate them before and then 30 minutes after, so we can see that objective, benefit of the high volume lumbar puncture. I'm also sending that spinal fluid off to Mayo Clinic to get Alzheimer's biomarkers, right? Because that can be helpful in kind of determining, hey, do we have some copathology going on? So these cases often get a lot more complicated the further you delve into it, but that is a reason for biomarkers, particularly for those primary progressive aphasia folks. Are you dealing with an Alzheimer's process? Are you dealing with an FTD process? Biomarkers can help clarify that, as can the FDG PET scan, which for most folks, I start with the FDG PET scan because that's a clear FDA indication for it and it's less invasive. But if the PET scan comes back in a gray zone or indeterminate zone, then I go to biomarkers next, and that's part of my process. All right, very good questions. What time do we have here? We're a little past time. So, but yeah, if you guys think of any, you can always send them Kelsey's way and we'll get some answers for you. What biomarkers do you order for CSF? Okay, so those are, there's an AD or Alzheimer's disease biomarkers evaluation that Mayo Clinic does. It's with amyloid, total tau, and phosphorylated tau. And then they give you a phosphorylated tau to amyloid ratio that basically tells you, is this patient clearly amyloid positive? And especially if you see that phospho tau abnormal, that's a positive tau biomarker. So there are other places. We used to order them through Athena. Athena was where we used to send our biomarkers. Mayo is just a lot easier for us because they also use Epic, and it basically, we see the results right in Epic. I don't have to get faxes and things like that. But Athena Diagnostics has a good one. There was one that was just FDA approved. So I have some stuff around here somewhere. It starts with an F. I think it's Fuji. I don't remember the exact name for it. That's another one. We just have the tubes that Mayo uses. We've got the kits. It's just a lot easier for us to do it that way. But you could certainly look around. The one that was just FDA approved would be a very good option if you're just kind of seeing what are my options out there, and is this somebody that I can easily work with. But oftentimes, because these biomarkers are sensitive, you do have to kind of have the kits and the special tubing before you do the lumbar puncture. So we've worked with our radiologists. It's our interventional radiologists that do our lumbar punctures. And we just have them store our kits, and then we communicate when we're doing these. So yeah, good question. Imodium for diarrhea. I hate giving extra medications for side effects of medications. So that wouldn't be my first thought. But if we're kind of like down the line of, okay, we tried splitting the drug, we've tried a different variation, obviously that's a cheaper way to deal with donepezil and deal with the side effects. You could do Imodium, but some issues then become these swings of constipation, diarrhea, things get a little complicated. So I'd like to try other things before doing that, but it's not an unreasonable thought. I don't know what your question is there, Susan, other than what I just said. Strategies for, yeah, so our next one is going to be focusing on, I had that one slide on behavioral issues. So we'll focus on that in the next one. So we're about 10 minutes past. So I am going to go ahead and sign off. So thank you all. Hopefully this was helpful. And I'm going to, we'll go ahead and sign off. So recording, again, these are recorded on the website, and then we'll have a link to the EADS document. So I'll send that over to Kelsey. All right, thank you.